public health, and not just the law itself.
Hi everyone, I'm Dr. Faisel Sayed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Today, we're talking to Dr. Jeff Brenner from the Jewish Board of Family and Children's Services about putting care at the center. Let's dive right in.
Dr. Brenner, it's good to see you again.
Good to see you as well.
You know, I wanted to know if you could share with our listeners, what was it that made you pursue medicine?
I was a super duper science geek, and there's only so many things that science geek could go on and do. So I decided I wanted to do medical research and applied for the school's MD PhD program. And I was really inspired by all the cool work going on back then in genomics. So I was going to do like transgenic mice and genomics and all that sort of stuff. I got deep into my lab work. I did 2 years of med school. And in that, I ended up working with a lot of students who were forming a student-run clinic. And when I went off to my lab, I finished second year of med school and was doing full-time lab work. And since I had time at my lab bench to do the scheduling for the clinic, I volunteered to kind of keep doing it. Well, I just kept getting pulled in deeper and deeper into this free clinic, and just loved my time there. And it was a Catholic run free clinic in downtown New Brunswick that was run by a Jewish family doctor, Steve Levin, who's still in New Brunswick, and Sister Margaret. And they were like the power duo. And they were just like, health and well-being were breaking out wherever they went. And they cared for immigrants from Central America, refugees, and homeless people experiencing homelessness in downtown New Brunswick. And the students would come in one night a week, and they both would, Dr. Levin would precept, and it's just so inspiring. And I started to realize just how sophisticated primary care could be. I always thought of it as like head colds and just boring stuff. And when you watched the cultural sophistication, the crossing class and race boundaries, like just that you could bring this science and this discipline of the research lab actually in to change people's lives and do it in a really thoughtful, kind, caring, and methodical way. I just saw a marriage of science and people in a very different way than I'd ever imagined before.
Wow, oftentimes that's a great disconnect. People in academia, and you got the community doctor out there, and here you found a way to bridge the two together. It's just wonderful.
You know, he could, cite evidence and studies and like do all the stuff the academic folks did. But the studies he was citing were like way more important, like how to actually take care of people. And, so, really, I ended up leaving the PhD program and going into the public health program and working on an MPH, and then going back to school. And like people thought I was like in outer space. Like I'm like, oh yeah, I'm going to be a family doctor. Like a family what?
Oftentimes, even now, we see with training, there's so much of an evidence with so much of an effort with having doctors learn these medical guidelines, these evidence-based guidelines. But the communication piece, like these evidence-based engagement communication strategies, are often they'll learn it, but they don't get to really practice it for several reasons. But why do you think that's happening?
It's a great question. I mean, ultimately there's always a fight in the curriculum committee over the curricular content in schools. And, it always seems like the reductionist stuff crowds out the supposed softer skills. I think about motivational interviewing is this incredibly powerful skill set that seems a little bit more important than the Krebs cycle, but I still remember a lot more about the Krebs cycle than I do motivational interviewing. I've since learned about it, and there's so many examples where there are just entire domains of knowledge that are just left out of the curriculum. My favorite example of that, where there's a real intersection of people skills and science, is in the human stress response. I mean, I think that's the way you unify social work, medicine, and nursing. is the human stress response. And there's a biochemistry, a neurobiology, a neuroanatomy, and there's a whole bunch of real world impacts of trauma, how it impacts people. And we just don't talk about it. We don't learn about it. It's really tragic.
It's interesting that you bring that up. I've heard it said that doctors, because you're asking the tough questions, but somebody might cry when you ask the question, and we've got to feel comfortable. I mean, it can be uncomfortable. You've got to be able to ask the uncomfortable questions. I mean, I've heard you talk about adverse childhood experiences and how important that is, but it's interesting how often we just let those things completely go by and want to talk about, um, you know, what they were eating, or really trying to blame the victim rather than really thinking about what's going on there.
We're very uncomfortable with being uncomfortable. And that doesn't work very well because the work we do is very uncomfortable. It's family medicine residencies quite commonly do something called a Balint group. And it was pioneered by a psychiatrist. His last name is Balint. And it's basically, they don't tell you when you're in it, but it's basically group therapy for stressed, overwhelmed residents who learn how to talk about their feelings and like process all the crazy shit they're seeing out on the wards. And it's very powerful. You spend a year with each other, not as colleagues and residents, but like really unpacking all this stuff. I don't think that's spread to the other fields. I don't think there's a safe normative space in which med students and physicians can unpack all the incredibly intense stuff. So they learn to dissociate, and they're taught to dissociate. And dissociation is a really important skill, professional skill. Like when you are cutting into the human body, you need to not spend that much time thinking about it because you just got to get the surgery done. But you also have to, at some point, unpack and process. We have really high rates of divorce and depression and suicide, all this like stuff. In social work, when you walk in the first day social work school, a lot of schools, they put you in individual counseling and in group therapy, and you like learn to unpack all your shit. We don't do that with physicians. It's really doing them a disservice. And that Balint group was very powerful for my training.
It's one of the things we see with our healthcare workers in our neighborhoods. So we have our centers exist in the same neighborhoods where you typically see the federally qualified health centers, the FQHCs. And our patients are the patients from those neighborhoods, but the seniors, because we work within the Medicare Advantage. So we only work with Medicare Advantage, full risk Medicare Advantage. So our average patient's over 72 years old. So you can imagine the population we're looking after. So not only are you're looking after the neediest communities, but the most vulnerable from those needy communities. We have a center in St. Louis where more than 90% of the patients rely on us for transportation services. I mean, that's a population. So the workers who are very passionate about, using the full flexibility of the full risk model to really impact change. I look at the people who leave, who just can't. They say, "Hey, I've never experienced this type of suffering." It takes a special person to naturally have the resilience to bounce back. Okay, I just dealt with a gut. I was in Wichita yesterday, and we had a couple come to our center. We have a temporary location there. There's been some delays with getting our official buildings established. And the couple came in. The husband and wife, one drinks water for the meal, and the other person eats for the meal. And then the next meal, they switch. And then the husband will eat the meal, and then the wife will drink water. And so this is something that we encounter pretty much on a regular basis when you're working in the neighborhoods we're working in. But for our staff and our employees and our physicians, many of them are not, they're not used to having to, how do you approach this problem, especially when you're working within a system where you don't have that flexibility. So I think that what you bring up is a critical point, because we see that all the time with doctors. We see that doctors and nurses, and I'm particularly worried now. We have somewhere like close to like 2 out of 5 doctors are nearing retirement age.